All right, thanks everybody. Thanks for joining another ANL webinar. Today, it's really glad to enjoy Professor Phil Levi. He's from Boston Children's Hospital, Harvard Medical School. And I met Phil, 15, maybe 18 years ago, when we both started to explore speckle tracking. And what I clearly remember back in the days, Phil went on the right heart and I went on the left heart, and we had these discussions back and forth. You're doing the wrong ventricle. But over time we built this huge amount of ultrasound sort of information and skills. And Phil is definitely one of the persons out there who has a lot of skills in looking at sick babies with ultrasounds and novel ultrasound technologies. Today, he's going to talk to us about our good old friend, I call it, the patent ductus arteriosus in preterm infants. Every day on the rounds, we discuss the PDA. Every day, we don't know exactly what to do. So I've asked Phil, maybe you can come with something where we talk about this PDA and the actual sort of matching the evidence to the experiences, particularly when we go to the scenario of procedural closure, like final closure. That is usually a hard decision. So, Phil, over to you.
Awesome. Well, thank you for the invitation. It's just great to be here. As Kurt said, we've had a kind of a long-standing relationship. I've learned a tremendous amount from his work, and I'm sure many of the people on this Zoom from your work. So, going to take a little different approach. I will kind of talk about some of the age-old questions around the PDA, but I'm going to focus more on, when to consider procedural closure of the PDA. This is a QR code to the talk. It'll come up at the end as well, so feel free to kind of take a picture now, and then I'll get a picture back up kind of at the end. Just some simple disclosures and disclaimers. Have a couple grants and do some speaking engagements, but this is what it feels like to be in the world of the PDA. It's a constant roller coaster, but hopefully, by the end of this talk, you'll have a little joy like I do. My disclaimers are the Bitmojis you see on here come from my 14, 13, and 8-year-old who 6 years ago lived during COVID, and I have tasked them ever since with creating Bitmojis for all of my talks. So I have kind of three questions I want to explore. What are kind of the initial approaches and considerations to attenuate a PDA that may cause cardiovascular compromise? I'll briefly talk about this. We'll spend more time in the Q&A on this. I want to talk about the trends for definitive closure of the PDA. I want to talk about this device occlusion. I know it's something that is evolving in your part of the world, and I was introduced to it about 2019. And then when would you even consider device closure? And then how do we prevent what I call post-PDA closure decompensation or post-closure syndrome? So we'll run the gamut in the next kind of 40 minutes, and I'll leave about 15 minutes for talking. So, of course, you always have to talk about defining hemodynamic significance. And this could be a 3-hour talk or a 3-day symposium, but this is my analogy. So you have a physiological patent ductus arteriosus. It's a patent ductus that just remains open beyond its biological role. It's not actually causing a problem. So in this situation, it could be the dog in the car or the dog in the back seat, but it's not me driving the car. And that's opposed to a pathological PDA. So that's when you have a PDA that's not only patent and open beyond its biological role, but it's a PDA where you have a high volume shunt that is going to cause cardiovascular compromise. And in this analogy, it's when the PDA is driving the bus. The classic example that I like to share with people is you have a PDA at 14 days of age. You have classic symptoms, increased respiratory support, lactic acidosis, widened pulse pressures. You get an echo. There's all the classic signs of the PDA. But could it be sepsis? Could it be RDS? Well, if you had an echo at day 3 or day 4 that showed a wide open PDA, and you had an echo at day 14 that showed a wide open PDA, then maybe it's the PDA. But if the echo at day 3 showed a very small PDA, and the echo at day 14 was now wide open, maybe it's the sepsis that opens up the PDA. So it's really trying to determine who's driving the bus. And the timing of the interventions has to be based on the total assessment of the infant's condition, including clinical parameters and what I like to call longitudinal echocardiographic findings in the expected course. In other words, are you a passenger or are you driving that bus? But really, in order to understand the role of the PDA and its impact on our patient population, you have to understand the natural history of the PDA. So, what are the facts based on the literature? We know that in babies born less than 26 to 28 weeks gestational age delivery, 20 to 40% of the PDAs close by 2 to 3 weeks of age. 40 to 50% remain open. They may be significant on echo, but they're clinically irrelevant. So we're really talking about a very small percentage. Not all PDAs do this. So for me, it's about 5 to 10% that could cause long-term issues. And as my wife comments, I'm wrong 50% of the time. So it's probably 2 to 5 PDAs out of 100 kids less than 28 weeks where we're worried. And it's in these kids where you have an increased risk of morbidities with a moderate to high volume shunts. So for all the naysayers, I agree with you. We're not talking about the 98%. We're talking about the 2 to 5%. So the options to attenuate a PDA, I think everybody knows this, but I like to use similar terminology. You have expectant or conservative or supportive, and then you have active, where it's pharmacotherapy, and then the definitive is transcatheter or surgicals. And that's where we're going to really focus much of our talk for the remainder of this time. So what we can talk about in the Q&A is screening practices or how to assess hemodynamic significance or PDA score, or even some of the newer literature on expectant versus active therapy. For now, what I want to do is I want to set the stage. We're beyond the fork in the road. We're focusing on the 2 to 5%. We are here. So for me, it's really about when would we consider definitive closure? So surgical ligation or transcatheter device occlusion. So it's really ongoing cardiovascular compromise due to the PDA driving the bus, where you have failed medical or pharmacotherapy approaches, or you have a contraindication to pharmacotherapy. So the standard of care for definitive closure beyond infancy in those kids greater than 5 kilos has always been transcatheter device occlusion. That's important to recognize. But the standard of care for definitive closure in an ELBW or a VLBW historically has been the management that has been limited to surgical ligation in infants under 1,000 grams. And we all know the respiratory and major risk factors with surgical ligations, from lung collapse to vocal cord paralysis to thorax deformation. So, 5, 6, 7, 10 years ago, the question was, is there an alternative to surgical ligation? And the answer is yes, there's an alternative, and it's device closure. This is just one example, the Ampletzer Piccolo occluder. We have 2 outer discs and a middle disc. Here's a nice cute picture of a baby. Here's our classic picture of the PDA with a right to left shunt, the arch in red, the pulmonary artery in blue. And here we have this procedure where it's going to be femoral vein access. There's no arterial access, where we go up through the IVC into the right atrium, right ventricle, out through the pulmonary artery, across the PDA. It's using a combination of echocardiography and angiography, where we can then deploy a device. Here's the first disc, the middle disc, and the last disc, and using angiography and echo to confirm placement between the PDA, not either on the aortic side or the pulmonary side, and then we release the device. So that's the framework for people who have never seen this before. Again, there'll be a QR code to the talk, but I'll walk you through kind of the process. So back in 2019, the FDA approved a device down to 700 grams. It was based on this initial study in combination with the Abbott group, where they had gestational age medium of 25 weeks. They had 100 children. Crazy to think the FDA approved it based on 100 children. The age at implant was just above a month. The weighted implant was about 1,200 grams. The successful implant was 99%. They had 2 embolizations and 1 migration. There were no overall major complications, no open surgical ligation, no death. There was no residual shunt at 6 months, and there was no LPA stenosis. There was 1 aortic narrowing. So overall, from this first study, people determined, and the FDA determined, the Piccolo is minimally invasive option for closing the PDA, but its effectiveness at improving patient outcomes was unknown at this time back in 2018, 2019. So the question has always been for me over the last 6 years, is device closure feasible and safe in premature infants? Well, we now have this data from over 1,500 caths that it's technically feasible, 97%, and there's very few complications. It's not only become feasible in smaller and younger babies, the weighted intervention and the overall time at the procedure has gone way down. Now, the adverse events reported in the literature don't have much to do with the weight or the age of the babies. They more have to do with the volume and the high volume versus low volume centers, where if you're a low volume center, you're more likely to have complications than if you're high volume. So the summary here is that if institutional experience and expertise is available and the patient characteristics are suitable, device closure may be considered as an alternative to surgical ligation. So basically, back in 2019, with this preliminary data, we decided that we needed to build a program, and we determined that we needed to what I call see the Wizard of Oz, or the interventional cardiologist. And yes, there are people out there that don't believe in closing the PDA, and I equate them with the Wicked Witch of the West or East. And my 14-year-old made this Bitmoji saying the interventional cardiology makes the Wicked Witch go away. But my 13-year-old says, no, Dad, the house falls on the Wicked Witch. But any way that you slice it or dice it, to me, we built a PDA closure team that was multidisciplinary between cardiology, neonatology, CT surgery, respiratory therapy, and nursing, where our philosophy as a program is to get rid of the PDA in the least morbid way possible, which does not necessarily mean device or ligation or even pharmacotherapy. What it means is we have a longitudinal follow-up with tracking all of these PDAs to help us really discern which PDAs need to be closed. We have a whole team. We have a perioperative assessment where we work with referring hospitals to get the babies in. We have neonatology and cardiology assess them. If they're not eligible for PDA device closure, then we involve our CT surgeons. If they're eligible, they come in, they get prepared for intervention with our cardiologists, anesthesia, CT nursing, cardiology, neonatology, and then we have a whole paradigm for post-operative care to safely get them back to their home institutions. So the typical procedure looks a little bit like this. You have a referral process with a robust review, and we determine the eligibility. For us, the babies need to be about 700 grams or greater. They need to be older than 3 days of age to avoid any complications of acute pulmonary hypertension. There can't be any evidence of coarctation of the aorta or LPA stenosis because the device can be close to either of those ends. We can't have a cardiac output that depends on the right to left or left to right shunt like we do with PPHN. There can't be any infection or thrombus. And there's certain criteria for the length to be a certain length and the width to be a certain width. If it's too wide or too short, the device can't sit properly. We assess the PDA with morphology. So there's 6 different morphological types of the PDA. We're focused on this type F, which is most common in the premature population, long and tubular to allow room for the device to sit without protruding on either side. We then measure with echocardiography using that high parasternal long axis view. We measure a minimal ductus length and a ductus diameter, and basically allowing us to really understand, is this the right PDA that could be amenable to device closure? And then there's the typical procedure. We've determined that the babies are eligible. We obtain an echocardiogram on the day of the procedure. We safely transport the babies from the NICU to our cath lab. Now, there are certain NICUs around the country in the United States where they perform the procedure at the bedside. And there is one program where they have traveled to the referring centers down in Memphis and also in Germany to do bedside procedures at referring hospitals. So preparing the catheterization suite, it's as you would imagine. We turn the temperature up almost to 80 degrees. We have heat lamps and bear huggers because we have these 700 grams that will spend about 30 minutes to 60 minutes outside of their isolates. We have an echocardiogram machine. We have hemodynamic support and blood pressure support. We intubate all our babies in the NICU, and we use a NICU ventilator if they're less than 1.5 to 2 kilos. And we send all babies to the cath lab with 2 points of access. And we try and avoid a pick in the leg because that's where the interventional cardiologist needs to access the femoral vein, preferably on the right side, but they can do left side. Now, the ventilator is interesting. We generally will use conventional ventilation. There is some programs that will do this on high frequency ventilation. Here's just one example from the Iowa group. They have shown that it is feasible and safe. It did not increase any cardiac or neonatal morbidities. And the Arkansas group actually from this paper, which is really nicely done, does a schematic where they even show where they put the ventilator in the room. It's both feasible and safe with both an oscillator and a jet ventilator. So this is an evolving field with the mode of ventilation. Our vascular access, as I mentioned, is only venous access. We don't do arterial access. That's what makes this so novel. We use ultrasound to guide the femoral venous access, as shown here. This gets in the weeds here, but we do a 4 Fred standard sheath. The first ever cath procedure, which was done in 1967, was a 16 French, 4 times this. And the first neonatal was done by Rashkin in 1976 at Children's Hospital of Philadelphia. That was an 8 French, just showing you how the field has evolved. So this is a nice video here where you can clearly see there's a balloon at the end of the catheter. It is going from the right atrium to the right ventricle, and a balloon allows a safe crossage through the tricuspid valve to minimize tricuspid valve injury, which was a problem early on. Here is the deployment of the wire going from the right atrium, right ventricle, through the pulmonary artery, through the PDA, and then down the descending aorta. This is preparing us to next put in a dilator. And once you have the dilator that comes up again, right atrium, right ventricle, pulmonary artery, through the PDA, down the aorta, you're now in position to be able to do the appropriate angiography. So again, remember, it's a combination of angiography and echocardiography, where they're doing angiography, minimal amount, and then they're able to measure the PDA to get the length and the diameter, where they match the length and the diameter up to what they saw in echocardiography. And this is what helps determine the actual size of the appropriate device to place inside of these babies. And I don't know how the cath people do it, but they take a 2-dimensional picture and understand the 3-dimensional anatomy where they have landmarks with the endotracheal tube, the thermal regulation, as well as understanding where the RPA, the LPA, and the MPA are located. And as I mentioned, it's a combination of echocardiography and angiography. And here's just a kind of a caricature that puts it all together, but really understanding that you're trying to know exactly where the PDA starts and ends on the PA and aortic end, so you can put the device as neatly in the middle so it's not protruding on either side. Here are the kind of the list of devices that have been used in babies less than 2 to 2.5 kilos. The most common one is the ADO2 or the Piccolo. That's the only FDA approved device in the United States. There's also an AVP2. There's a microvascular plug, and then there's the KA plug. And as I mentioned, it's important to understand that the Piccolo is the only FDA approved device. So here's just a picture of it. It's a nitinol kind of nickel titanium alloy. You have 2 retention discs on the end and a central disc in the middle. This is as opposed to the MVP or the microvascular plug, which is composed of this kind of self-expanding frame where you can see that there is kind of distal markers and proximal markers and then a sheath covering it. At Boston Children's, we have 2 of these devices. We have the MVP and the Piccolo. Most centers have at least 2, if not 3 in stock. So basically deploying the device here, slowly manipulating with the interventional cardiologist. They're pulling back the wires. And in a few moments, you're going to see, and I'll highlight it, you're going to see the deployment of the discs. They're getting it right in the PDA. So it's very nuanced, making small movements, deploying the first disc. And then you'll see in a moment, they'll deploy kind of the second disc. The first disc now is just out, that far distal kind of area. And then the second disc comes out. And now you can see the whole device is out in the middle there. So again, as I mentioned, you're using echocardiography to make sure it's in an appropriate position and not, for example, having LPA obstruction. So they're evaluating dislocation, residual shunt, aortic obstruction, LPA obstruction. And here's just an example where they can get echo in real time. The red lines are where the wires are. The wire is still attached. And we make sure that the device is in a good location. It's not protruding in the aortic or the pulmonary ends. And there is very minimal residual flow through the device. That device, minimal residual flow will go away over time as the device narrows down. And once we feel we're in a good position, we detach and the device is released and the wire is no longer located there. And then we look at where the device is located. If after we detach and we feel the device shifts, we can actually put the wire back and what we call snare the device and then reseat it as needed. So the procedure is not new, but the key differences with the care of the premature infants, it's a highly coordinated team approach. It's management before, during, and after with all of the different specialties you see on the screen. There's no arterial catheters, and it's true, neonatal hemodynamics at its core with echocardiography guidance and fluoroscopy in real time. So the follow-up for us is we get an echocardiogram at 1 day, 1 month, and 6 months, looking for, again, migration, embolization, and flow through the PDA. We do SVE prophylaxis for 6 months for any GI/GU procedures, and it's MRI conditional. Now, there is some talk about getting rid of the follow-up echocardiograms. When you do a ligation, you don't get an echo the next day. There is one study from China that looked at 1,500 patients and found that if you had no adverse events on the follow-up echo at 1 day of age, you were not going to have any adverse events 1 month, 6 months, 1 year, or 3 years out. So for me, as long as you're building a new program, I still advocate for the 1 day and the 1 month echo. I think over time, the 6 month follow-up may go away. So what are the weight restrictions? We have placed devices down to 560 grams. What does the literature say? Well, the literature says that it's not about weight or gestational age. It's, again, back to the high volume center. So the rates of major complications in babies less than 700 grams was relatively low, and they were higher in the low volume center. So it can be done, but you should have a little caution. Everything that I just presented was just published in SCAI, Society of Cardiovascular Angiography, where they talk about the patient selection and the criteria for transfer with communication, considerations, and everything was nicely published in this checklist. I know this is small. Again, there'll be a QR code at the end of the talk, but basically you have pre-procedure, procedure, and post-procedure considerations, everything from the management of IV access to intubation to procedural considerations with thermoregulation, and then the post-procedure considerations with sedation, choice of ventilation, and even medications to mitigate post-ligation syndrome, which we'll talk about. So when you're trying to build a PDA closure team, these are the lessons that we learned. You need to have institutional stakeholders from NICU, cardiology, anesthesia, RT nursing. Identify the referral centers in your region and cultivate and grow relationships, share national data and trends, develop an infrastructure for referral, establish perioperative and postoperative workflow, create follow-up and discharge instructions, develop a QI registry, and that's what we've done, and appoint a lead coordinator, and then cultivate this into academic endeavors, work with trainees and fellows to grow your programs. So this is what the data looks like. This is some national data in Figure A from our FIS, Pediatric Health Information Systems in the United States. Overall, the combined definitive closure rates have dropped over the last, this is now 5 years old data, but it's still reflective. Ligations have gone way down, the red squares. And in 2019, you can see that inflection point where device closures have gone way up. This is our regional data in Figure B from Boston Children's in New England. And you can see a similar trend with a drop in ligation and a rapid rise in device closure. So our data looks like this. This is now closing on 6 years worth of data. We've had about 300 referrals. About 30% of our referrals never come for device closure. So that's another take-home message is just because you do referral doesn't mean it leads to closure. We've had still 36 ligations. I'll talk more about that in a few moments, and 167 cath procedures with multiple different devices. No intra or procedure related deaths, but we've had 11 pass away that are in the registry, which mirrors kind of the national data. Two passed away in the first week post procedure, again, not related to the procedure, and nine passed away from either BPD or sepsis months later. So what does our data look like? We have about a 97% success rate. We've had 162 out of 167 leave the cath lab. Interestingly, one came to the cath lab with no PDA. So now we echo all the babies on the day of the procedure before coming. We had three come to the cath lab, and the PDA was just way too big. Two of them needed a ligation, and one of them closed the next day, probably from the manipulation or irritation of the PDA. And one baby unfortunately had a tracheal tear. So now we intubate all of our babies, a tracheal tear from intubation prior to the procedure. So we intubate all our babies prior to going to the cath lab. Here's what our data looks like. Median is about 25 weeks. Birth rate was 805. We do it about a month of age. The weighted procedure is about 1.5 or less. Pharmacotherapy, about 2 courses, 1 to 3. Our smallest has been 560 grams. Our youngest is 10 days. And we've had all the normal complications reported in the literature: aortic migration, LPA stenosis. We had one baby who had a migration with an aortic kind of coarctation picture where we had to watch it for 9 months, and eventually the CT surgeon cut it out at 9 months of age. So should surgical closure or catheter device be the intervention of choice? That's always the question. So you can't do a randomized control trial because equipoise is lost. Many centers don't do ligation, but if you look at observational and retrospective studies, device closure compared to ligation leads to less mortality, less post-closure syndrome, which I'll talk about in a few moments, protects against ROP and PVL. There's really no difference in BPD, neck, or IVH rates. Some say it's better, some say there's no difference. But there are some improved respiratory outcomes. You wean to extubation quicker, and you have decreased length of stay. There is a similar cost between device and ligation. So who still gets ligated? I think the barriers are this: there's awareness, there's experience, there's transportation, there's cost, there's knowing outcomes. In our cohort, basically post 2019, where like device occlusion was eligible, about 26 babies still underwent surgical ligation. The majority of them was truly for abdominal pathology. So somewhere between 10 and 14 days with active neck or an active infection where the PDA was driving the boat and we wanted to close the PDA, we had to defer to ligation because we didn't want to put a device intravascularly where there's active infection. So then the question would be, what is the ideal time up to when can you close the PDA? So with a device. So if you identify a baby who needs a device, nice study from the Memphis group comparing devices that were put in less than 4 weeks, 4 to 8 weeks, and 8 weeks, and found that if you put the device in less than 4 weeks of age and those kids that needed, they had faster times to extubate, quicker improvement of respiratory symptoms. So that was the first indication that up till about a month of age made sense. But that didn't take into account the morphological pieces of the story. So the ideal PDA is a type F fetal PDA. But what we learned from our colleagues in Atlanta is that that type F seems to switch around 34 weeks, and it's no longer long and tubular. So when they looked at their own data in Atlanta, they found that under 34 weeks, it was a type F highlighted in orange, and over 34 weeks, it was the non-type Fs. But the type Fs, which is highlighted in that kind of second column, they had less time in the cath lab, less exposure to the contrast, less procedure-related complications. So when you put this all together, what we kind of have advocated for is that not only do you advocate for early referral, but timely device closure. So you have up to about 31 to 34 weeks or 4 to 6 weeks of age to really close that PDA, which really speaks to the tracking and longitudinal following. So if you just got a moment in time echo and it showed hemodynamic significance, I would advocate for maybe you should follow that. Maybe you should get another repeat echo. You want to do some pharmacotherapy? We could talk about that. But you have time to make that decision process. You don't have to rush and close it the minute you find that PDA that is significant. So just a moment about different approaches to screening, and this will tie into kind of when to consider procedural closure. So are you a risk-based? Or are you a symptoms-based? So I mean high risk, medium risk, or low risk, or based on symptoms. So some centers around the world, they screen based on risk. So if you're less than 26 weeks and you're intubated, they may get an echo at 1 to 3 days of age. If you're 27 to 29 weeks, you may do it closer to 5 to 7. Or most centers around the world are based on symptoms, less than 7 days or greater than 7 days. When I did a national study through the Children's Hospital Neonatal Consortium in the United States and North America, about 21% seemed to screen less than 3 days, so that's based on risk, and 80% screen based on symptoms. In Boston, we're more of a symptoms-based screening program, but in Iowa, they're more of a risk-based screening program. So to me, if you're looking at screening and you're doing it based on symptoms, you may totally ignore the PDA for the first 14 days, or the latest Cochrane says maybe have a conservative approach for the first 7 days. But either way, you get some echocardiogram, you have some symptoms, and you have this echo at 7 days that shows a duct that's significant. You start some ibuprofen as this example. So the earliest you would consider definitive closure is probably about 10 days of age. Now, if you're a risk-based screening program and you're going to get an echo at 1 to 3 days or 4 to 7 days, somewhere in that, you might have an echo that shows a duct that's significant. You might have some clinical signs, and you might give some pharmacotherapy. If the duct's still open at 7 days, well, you might give some more pharmacotherapy. So the earliest that you would consider device closure in this paradigm is still kind of 10 days of age. It gets you beyond the risk of IVH. All the major complications have been less than 7 days and in these low volume centers. So this is a nice article that was published last summer. It talks about the who, less than 26 to 28 weeks. It talks about the when, really greater than 10 days of age, gets you out of the procedural complications, gets you out of the risk of kind of transitional hemodynamics, possibly IVH risk is lower. It's really the 10 days and still intubated. Those are the higher risk babies. You have some echocardiographic criteria, which I'll talk about in the Q&A, pulmonary overcirculation, systemic hyperperfusion, systemic steal, pharmacology, 1 to 3 courses. However, there have been some babies where I've totally skipped pharmacotherapy and gone right to device closure if they're older than 10 days of age. And finally, device over ligation with institutional experience. Here's just a snippet. How many courses of pharmacotherapy would we do before definitive closure? We get a lot of insight from this article that was published about 10 months ago. If you give one course of pharmacotherapy, your effectiveness rate is 60% per se. It's about 50% if you're less than 26 weeks, closer to 70% if you're older than 26 weeks. Second course is 25% effective, and the third course is 8%. We know there's a high rate of failure when we get to the second and third course, but if you're less than 26 weeks and you failed pharmacotherapy twice, the chance of you having a response is 0% in this study. So what I tell people is that if you want to try pharmacotherapy, that's fine. If you're under 10 days of age and you think that duct needs to go away, that's fine. It's going to be somewhere in that 50 to 70% effective. But once you get to that second course of pharmacotherapy, if you saw a response with the first course, by all means, try it again. If you have to wait for transfer, by all means, try it again. But you have to really be thoughtful because giving pharmacotherapy is not a freebie. Plus, if a baby has a PDA that needs to go away, and pharmacotherapy is only 60% effective, and there could be some side effect profile, you have to really decide, do I take my time with pharmacotherapy or do I just jump to the minimally invasive approach? At Boston, about 11% of our babies have gone to the cath lab without getting any pharmacotherapy, but the median time both in Boston and the national registries is somewhere around 2 courses of pharmacotherapy. Okay, the final question for me is, does low cardiac output syndrome occur following transcatheter device occlusion? When I first started this back in 2018-19, I told everybody there was no post-ligation, post-closure syndrome following device occlusion. I was wrong. We have these high-risk patients, we have definitive closure, and then there's a honeymoon period for about 6 to 12 hours. Then there's a period of clinical instability and increased morbidity. I've seen hypotension, ventilation goes up, oxygenation goes up. So the reported incidence is about 45 to 50% following ligation and 20 to 25% following device closure. So let me show you what happens. So we know in the preterm infant, you're trying to optimize your preload, trying to minimize your afterload, optimize your contractility, but we know there's abnormal contractile forces that makes it immature and inefficient in the premature infant. We know the Frank-Starling curve is impaired with diastolic function and abnormal relaxation in the preterm infant. And we know that the way the afterload and contractility responds due to force frequency is also impaired in the premature infant. So basically, if you have too much or too little preload, too much or too little afterload, all of that affects the way the heart contracts and relaxes. So what happens? Here's the natural left to right shunt. You have too much preload, not enough afterload. You close the PDA, all the blood going to the lungs. Well, guess what? It goes out to the body. And the analogy I use is when I got my braces off in high school, all of that, all the girls rush towards me with my braces off. So the afterload goes up. They can't handle all of the new blood flow to the systemic circulation. Well, as afterload goes up, guess what? The contractility can't handle that. The contractility and the blood will not go from the LV to the aorta, it'll go LV to LA, and then you'll go back into the pulmonary system. And this next slide really kind of sums it up. The 6 to 12 hour phenomenon with a rise in afterload, you have decreased contractility. There's phase 1, phase 2 in this ventricular vascular coupling. LV afterload goes up, LV performance meets its demand. But by the time you get to stage 3, the LV performance uncouples from the afterload, decreased work, decreased stroke volume, decreased cardiac output. You have decreased systolic blood pressures, and you end up in shock. Well, guess what? You also have diastolic impairment. So that blood is backing up. You have increased LA pressure, increased pulmonary venous pressure, pulmonary edema, decreased pulmonary compliance. And you end up with hypoxia and impaired ventilation and hypotension. And that's the phenomenon of low cardiac output syndrome. Here's your x-ray. 6 to 12 hours later, the x-ray looks worse. Your mean airway pressure has gone up. Your FiO2 has gone up. Your CO2 has gone up. And you've done a reverse of what you set out to do. And that's the post-ligation syndrome. So to answer the question, does it occur following device closure? Yes, it occurs. This is a study from 4 centers, prospective studies, where it found 23% of babies had some element of the systolic hypotension, increased ventilatory or oxygenation needs. So the question becomes, how do you prevent it? How do you mitigate this? So we need to figure out a way to increase the honeymoon period and have a prophylactic approach. So thankfully, milrinone or dobutamine is another alternative. You have increased contractility based on the skeletal muscle, and you have increased vasodilation where you lower your afterload. So we know the afterload will go up. Milrinone lowers that afterload. We know there's poor contractility in times. So all of this will help us mitigate the post-ligation syndrome. So we use a cocktail of 3 interventions. We'll give milrinone, we'll give a sedation. So either go up on our sedation by 10% or initiate low dose sedation for 12 hours to mitigate the catecholamine response with agitation. And then we'll adjust our ventilation. So we really focus on the respiratory severity score, which looks at mean airway pressure times FiO2. So we know there's a honeymoon period. So rather than lowering our respiratory support, we either keep it the same or we'll escalate it sometimes from conventional onto the jet as needed. Then 12 hours, 18 hours, we get our first echocardiogram and we start to peel back all of this support. So in summary, I hope I've shown you that device closure of the PDA is feasible and safe in premature infants. There's been a rapid adoption of device closure of the PDA since 2019 that's reflected in all of the national and international trends. I think device closure will lead to improved short-term respiratory outcomes, decreased morbidity, decreased length of stay, decreased low cardiac output syndrome, and lower mortality compared to ligation. So I always like to kind of end with this slide. This is a QR code to the talk that I'm happy to share. I think that we need to be honest with families and each other and adopt a culture kind of of support that will help us build and develop new precision diagnostics and clinical programs for neonates with cardiovascular compromise. As I end and begin to answer questions, I think in our lifetime, for those who have been practicing for a long time, we've seen surfactant replacement therapy, antenatal steroids, nitric oxide, cooling, advanced ventilatory strategies, nutrition. I think one day in 20 years, we'll look back and think about how device closure has changed the impact of our smallest and sickest babies. With that, I'm going to stop sharing and I'm happy to answer questions. I'm sure there'll be a bunch related to screening and pharmacotherapy, but really just an honor to be able to spend this hour with you all, and I look forward to the Q&A. Thank you so much and happy to answer questions.
Thanks, Phil. That was an amazing overview and visually very, very impressive. Setting the stage is where you started off with who's driving the bus, which is normally what your psychotherapist tells you. Selecting the one I thought was a really good one, and then you went to this device and you showed us the devices. What I really liked, is how much we have progressed. Sorry about the background noise, some builders here. Um, how we progressed into not just doing a little scan and looking at the PDA, but we actually followed the teams which are doing that afterwards. Say, like you following your surgeon into the OR and oh, show me what you do and how you do it. And this particular part, which you and other teams in America are exceptionally well developing of a service. And the service is PDA closure, as you described. And then you showed us, what you need to do that procedure safely and well for even the smallest of our babies. That was just awesome. You had a little discussion about catheter versus ligation, which is interesting. The timing, which hopefully we should have some questions. Otherwise, we start with that. And that post-ligation syndrome was very, very elegantly explained. So let's start with a bit of questions. One, the QR code, I did already. Here it is. First question is about Thomas. He was about, when you're using that sedation, that was an interesting one. So to reduce the catecholamine responses, which sedation are you using in that particular aspect?
Yeah, it's a great question. In Boston, we primarily use fentanyl. What we'll do is if they're on some dose of fentanyl, we'll go up by 10%. And then after 12 hours, where the honeymoon period's over, we get a repeat echocardiogram, we'll go back to the baseline dosage. If they've never been on any opioid, we'll do just 0.5 micrograms per kilo, just a very small dose. There is some exploration to use Precedex. I think that could be a good option. I know there is some data or thoughts about the role of opioids and its impact on the brain. We do not use benzos in babies less than 34 weeks. So that's basically been our experience. My other experience is that you don't wait for the kids to get bad. You start it at the outset. There are some nice studies from Canada which says, why don't you just wait to see which kids will declare themselves? And people have then used either sedation and or milrinone and or adjusted the ventilator. But once you're into the kind of that honeymoon period ending at 6 hours, then you've already missed the boat. So great question.
So on that post-ligation syndrome where we're at now, the Iowa group described that it looked different. And I think in your explanation, I think it makes sense to me now. The initial part was all about the afterload, and maybe it's now sort of the change in preload and that diastolic function. What do you think? Is there a difference of where it leads to the end result of a baby getting poorer?
Yeah, no, it's a great question. If you ask people 20 years ago, they would have said it was a preload problem. That's what they said. They would have said all of the blood that was going to the lungs is no longer going back to the left atrium. So you have a drop in your preload. And if you have a drop in your preload, then there's less blood going from LA to LV, and then you're going to have a natural drop in your cardiac output. What we've learned actually from the IO group and your work and other people's work is that it is a kind of a progressive rise in the afterload. Now, I actually agree with you. I think you're not going to prevent the diastolic pressure going from 20 to 40 after closure or slowly going higher. You're going to see that rise in afterload that affects the contractility. What is a completely understudied topic is what's happening with the kind of the diastolic relaxation or the diastolic function. You have a natural drop in the preload. I actually call it a normalization of the preload. And I actually think one of the future initiatives is how do we address this kind of subclinical diastolic dysfunction, which, as you know, is very hard to measure. I think there's a role for things like left atrial strain. I think there's a role for advanced metrics of assessing diastolic dysfunction, but it's actually a reverse. 20 years ago, we thought it was preload and then afterload. Now I think we think it's afterload and then the preload issue and the diastolic dysfunction comes kind of as a last ditch attempt, a last ditch effort, which makes sense physiologically.
When you talked about research into your development of the service, and the research was partly just documenting what happened and sharing that with your people, which I think is awesome, just showing, what your service is, what is the complications. Is there like additional sort of really fancy research in there? Can you measure with a conductance catheter what the actual pressure or the shunt is during that PDA or that device closure?
Yeah, it's a great point. Three points. When we built our program, we also built a registry. So if anybody is thinking about building a program, we built a registry where we could share the REDCap database with you. That's number one. Number two is to answer your question. Yeah, I've always wanted to get advanced hemodynamics or advanced metrics while they're in there doing their cath procedure. Because how cool would it be to have simultaneous hemodynamics with echocardiography? Challenges are this: we don't have arterial access. That's number one. And number two is the way we sell the procedures, we try and get in and out as quickly as possible to mitigate any kind of adverse events, thermoregulation. So it is possible to grab kind of like an RV pressure from the catheter on the way out. So we have one program that's kind of looking into that. But really, to your third point, as you're building a program, both clinically and academically, I didn't really talk about this. One of the unanswered outcome metrics is neurodevelopmental impairment, as well as short term, what do NEERs look like? So in our program, actually, we do cerebral metabolic oxygenation, CMRO2, and NEERs. We do it before, during, and after device closure. We're gathering information. We have about 20 babies so far. And we are matching all of our 167 babies that we've done with 2-year neurodevelopmental outcomes with Bailey and other neurodevelopmental testing. So I think to your bigger point, that if you're building a program and you're tracking all of these kids, you need to understand both the short and long-term outcomes and use kind of not only advanced echocardiography and hemodynamics, but use other measures to assess cardiac output and systemic perfusion. So just that's a wonderful point.
Oh, that's awesome, because we really need people who do these large volumes, which I thought was over 50 a year, or is it over 20? I can't remember. What they call a large volume center, to give us that information for the starting point. I was just wondering though, if we don't have those numbers, and we're a small country and divided in different areas which are far apart, so we probably not even get to those kind of numbers. So how do we manage that? How do we build up a better skills here?
Yeah, it's a great question. So, the way they defined the high volume centers, initially that they defined it, you were doing 10 or more cases a year of PDA device closure. I actually have redefined that. My own opinion is you have a cath lab that is doing 10 total cases a year. And if you have a cath lab in a hospital, the chances are you're doing more than 10 cases a year. The reason I say that is this is not a new procedure, right? Where this is the metrics, the details of going through the procedure are the same. In Boston, we were doing 1,600 cath procedures a year. When we started doing device closure in 2019, these were some of the best interventional cardiologists in the world. The other way that we really built it up is we had proctors. We had interventional cardiologists come from other institutions who kind of watched over and proctored our interventional cardiologists. Everybody swallowed their egos. They did the procedures. And then the third way is really kind of what we're doing right now. So if you're in an institution and you have questions about how do I manage the post-ligation syndrome, or what dose of opioids do I use, or what is the dose of milrinone do I use, you phone a friend. So it's really, you're not alone. So you may be in a center where you're building a program, but you could utilize all the resources around the country. What we did in Boston, the regional area, we were the center initially, but now they do this procedure in Connecticut, they do it in Maine, they do it in Albany. So these are hospitals that are now within 100 miles of our hospital. So it starts slow. You have people help you, and then you have to help other people in your region to build this up.
Yeah. Look, that's an awesome story. And like I said, I think you guys, and I mean the Americans, are exceptionally good at that in setting something up, making rules and how to do it, give a pre and post checks, and make sure that everybody goes to their accreditation and keeps their skills high, and then reach out to everybody to say, how do you do it, and make this sort of national, often kind of recommendations. That's just an awesome feat, which I have to give you all, as we are learning from that and really want to take that on. For this group, I also want to say, indeed, the hemodynamics world is very open, and everybody is very easy to reach out to and just ask questions. No questions in the text box, Phil, so I think we're going to leave you to the longboard. He's in Hawaii at this moment, so, we're going to leave him to the longboard and the small little drinks on the beach. Thank you so much for this presentation. I hope to see you soon again on another presentation. Thanks everybody for attending. We will be back next week where we're going to talk about HIE this time. Okay. Thanks, Phil. Thanks so much.
Awesome. Talk to you soon. Thank you, everybody. Have a great day.
See ya.